We're going to be discussing infection control clinical procedures. I know you've already discussed Chapter 5 with transmissible diseases and Chapter 6 with exposure control and barriers for the clinician and the patient. But now we're going to go into more infection control clinical procedures and build on that, especially as you're beginning to see each other in the clinic as peer patients within the next week. In this chapter, we're going to be discussing the basic considerations for safe infection control practices and discussing methods for cleaning and sterilizing our instruments, as well as preparing and cleaning and disinfecting your treatment area, and some of the processes for our post-exposure management and also waste disposal in our treatment areas. The infection control procedures in the dental office and in our dental hygiene clinic, it's a planned system. The entire team works together to organize and maintain this process, and it involves sterilization, disinfection, care of the instruments, and all our equipment. For all appointments, you must consider your work practices, and these are developed and maintained before, during, and after our treatment to prevent direct or indirect cross-contamination between our dental personnel and patients, or one patient to another. The success of this planned system for infection control depends on the cooperation of each and every member of the dental team. We want to provide the highest level of infection control to ensure both a safe environment for our patients and also our clinical team, as well as we indirectly are taking care of our families as well. We want to eliminate this cross-contamination by breaking the chain of infection. Remember, we talked about that in Chapter 5. And this is for all appointments. And we're going to treat all patients with standard precautions. And that is basically we are treating all patients as though they are potentially infectious. So these are safe practices that we're always going to use in each and every aspect of our patient care in our treatment areas. We're also going to be discussing in our infection control the difference. I want you to be aware of the difference of sterilization, sanitation, and disinfection. First of all, sterilization. And that's a process that all forms of pathogenic bacteria, including bacterial spores, are destroyed by a physical or a chemical means, such as when we're autoclaving our instruments like you've seen in the sterilization area the other day. Disinfection, and that's usually something that's a chemical mean, and it destroys pathogenic microorganisms, but it may not kill the bactericidal spores, and this is applied on inanimate objects. Your book will discuss a wipe spray method. We use a wipe, dispose, and wipe again method, and we'll discuss that here in just a little bit. And then also sanitation, and that is a process that basically the inanimate surface or some of the microorganisms are reduced, but it's not necessarily making it free from microorganism. And this is basically referring to a cleaning process. There are three things that we have to think of when we're developing our practice routine in the sterilization and disinfection of our patient care items. And they're categorized into three following categories. We have the critical items, and these are items that contact with bones, soft tissues. These must be heat sterilized or disposable. Some of these examples can be surgical instruments, some of our scalers that we'd use, periodontal probes, scalpel blades, or needles when we are doing injections. Then we have what's next called the semi-critical items, and these come into contact with non-intact skin. These have a lower risk of transmitting diseases. However, they should be also disposable or processed with high heat sterilization. If some of these examples can be mouth mirrors or impression trays that we may use. And then we have what's called a non-critical item, and these items could potentially come in contact with intact skin, and they pose the lowest risk of disease transmission. the treatment room features that we want to consider when we have different materials and different contact surfaces when we're disinfecting our areas. And these contact surfaces are also considered non-critical items, and sometimes the choice of instruments that come in contact with intact skin. These can be contaminated by spray or splatter or by hand contact by the dental personnel. Contact surfaces can be disinfected with an EPA hospital level disinfectant, but we also want to use barriers whenever possible. And some of these surfaces can include light switches, drawer handles, faucets, pens, pencils, doorknobs, and some of the items that we think of in our treatment rooms. So looking at, some of our housekeeping, floor sink, waste receptacles, and these can be cleaned with a detergent or an EPA level disinfectant. In this image to your right, this is actually a picture from our dental hygiene clinic in one of our treatment areas, and that you will be assigned a specific treatment cubicle to work with your peer patient. And again, just kind of look at some of these contact surfaces that you may see. We've got the unit, we've got the light, we've got the dental chair, we've got the clinician chair, we have our floor that has no carpeting, our sinks have foot controls. Some sinks might have knee controls, not necessarily at our clinic. And then we have waste, and we have our biohazard and our sharps containers as well. This is an image from your text that just shows again some of the treatment room features that we see. We have a tray to your left where our supplies and sterilized instruments will be, and our disposable items. We have our sink. We have the clinician's stool. Usually we're going to be covering that at the back with some barrier protection. There's also handle covers on that chair. We'll cover those with barrier covers as well, so that way you will be able to touch that and adjust that and not cause any cross-contamination. We have our light that we use with barrier covers, and then we have our unit with our hoses that are easy to clean. They have our autoclavable hand pieces, and then our chair also has foot controls. It has controls on the main unit as well. So this just kind of gives, it's not exactly like ours, but it just gives you some of the area considerations for barriers and disinfection. Within the dental hygiene clinic, our instrument processing center is in the central sterilization area that you've seen. We will prepare our instruments for sterilization in your cassettes, and we'll also use your heavy-duty purple utility gloves that are in the clinic. Most of our items that we send down, that we utilize in the dental hygiene clinic, are all critical or semi-critical, and they are sterilized or either disposable. There's in an office area, you will see that there's separate areas for our contaminated versus our sterile instruments. Our instrument processing and recirculation, we start with the instrument cleaning and decontamination. We will either, in our dental hygiene clinic, we will, if it's a mirror, we will clean it and wipe it and put it back into your cassette. We will not scrub our instruments, but we will put them back into your cassette, and then they are sent down to the central sterilization area. These are, then next, the instruments which are packaged, which that's going to be your cassette, or sometimes they may be packaged such as your XCP X-ray instruments. Then they're sent down in packages to the central sterilization unit, or after they're run through the cleaner, which is kind of like the dishwasher, that is they're packaged down in central sterilization. Then they are ready for clinical use. Dental hygiene clinic, you can see in this image these nice pretty purple gloves. These gloves are our utility gloves. We will always use them for handling our contaminated instruments and also taking them to the in our box to the instrument cart. manual scrubbing for instrument processing is not recommended. That is, occasionally you may have to do that, but again, it is not recommended to manually scrub our instruments unless it's just extremely necessary. We're either going to run them through the instrument washer, which is in our central sterilization area. Some offices have this big dishwasher, or they're going to be run through an ultrasonic in some of your dental offices. This is an instrument washer that is very similar to what you've seen in our central sterilization area. Some offices I have seen that used a regular dishwasher. However, if you look closely at this image, you can see that in the instrument washer, there is actually areas where cassettes can be laid into these and stand up on their side, and then they're able to dry before packaging for sterilization. Another cleaning procedure is ultrasonic processing. This ultrasonic cleaning is done before sterilization, and it's much more safe than manual cleaning. Manual cleaning, if you're trying to scrub that instrument, is time consuming, and it can cause a potential for a sharps exposure, and we certainly don't want that. The ultrasonic is not a substitute for sterilization, but it is for cleaning. You have to take your instruments, and then they are in the ultrasonic cleaning for about 10 to 15 minutes. And then after they have been in the ultrasonic, you let them dry before they're packaged for autoclaving. In our instrument packaging, you must have that to help prevent contamination of the newly sterilized instrument. You must have the organization of these packets. There is always an indicator that shows if the packets have been adequately sterilized and ready for use and opening. And then each package is dated. And then also for the mark for content identification, such as prophylaxis, examination. The clear packages are much easier to see through, and so you don't often have to use special labeling of what the kit is. They can be organized into trays for your initial exam, adult patients. So it just depends on your type of packaging. Cassettes can be either wrapped or packaged in the see-through packaging systems, and then it's going to be usually a steam type of. Be careful that these are not punctured. If there's any type of puncture in one of these packages, then it renders it very quickly into a non-sterile type of package, and it would need to be re-sterilized before use on a patient. Once a sterile package has been brought in front of a patient, we do not open that package until we are right in front of the patient so they can see us open and make sure that that package of instruments has been sterile and has been opened just for them. If you look closely at this image, when I mentioned the indicator, any type of sterilization bag has an indicator on it, and these indicators are circled. You can see them circled in black, and then here's one. You can see it's a dark brown versus this one on the far right. It's still pink, and that means it has not been processed in the autoclave. And then afterwards, after it's been processed, it's going to turn kind of a dark brown. Sterilization equipment is cleared through the U.S. Food and Drug Administration, and it is always used according to the manufacturer's specification. The different methods for sterilization can be steam under pressure, which is what we consider our autoclave. Dry heat, chemical vapor, immediate use sterilization are also known as flash sterilization. We have some cold sterilization, which is not recommended to be used for very many items, if at all. And all materials and items cannot be treated for the same method of sterilization. So we're going to be discussing some of these methods in the next few slides. Method we'll be discussing is steam under pressure or through our autoclaves. Autoclaves will always have a weekly spore testing. I know they mentioned this in the sterilization area, and this is just to make sure this is done once per week, and this is just to make sure that our autoclave is working properly. Even though we have the bags that were shown earlier that give you that indicator with the first of all, when it hasn't been sterilized, it's pink. When it has been run through the autoclave, it turns brown. But that doesn't tell if it's reached high enough temperatures to kill all pathogens. And that's what the weekly spore testing will indicate. And also those records those are kept done weekly, and they're kept in a log for any type of checks to make sure that it is working well. The use of steam under pressure or autoclaving is the most commonly seen in dental offices form of sterilization. It's also the most economical. This sterilization is by moist heat, and it's that pressure as it builds up. If you've ever seen like the pressure cookers, pressure serves to attain that high temperatures. Remember this, 250 degrees at 15 to 30 minutes. Again, 250 degrees with at least 15 to 30 minutes to achieve sterilization. With proper sterilization, all forms of microorganisms are destroyed. One of the drawbacks of this is that if they're not dried properly before autoclaving, it can corrode these stainless steel instruments over a period of time. We're also going to be discussing some of the other methods. Dry heat sterilization is at very high temperatures for a prolonged period, similar to like an oven. You don't see those used very often. There is also a chemical vapor type of sterilization, and that is a mixture of alcohols and formaldehyde, water, acetone, and it's heated under pressure that produces a gas. This chemical vapor can't be used with all type of materials, and it can melt. So it's an antimicrobial, but it is something that the sealed packages would not prevent. If you have heavily wrapped or sealed packages, the vapors cannot permeate that packaging. So we don't use that or see that in dentistry very often. You might see that more in a hospital environment. Intermediate use of steam sterilization. It's also called flash sterilization. And this image right here, it shows it's called a statum. And this can be used to sterilize unwrapped instrument if they're needed immediately. I've seen this in offices where they were maybe using hand pieces. A lot of times you can package the instruments and then they're required a little bit longer time, but it's still less time because they have that very high heat. It builds up very, very quickly. You cannot do large amounts of instruments, but it does work well for immediate needs. And next we have the chemical liquid sterilization, and it's also called a cold sterile. With this, biologic monitoring is not really possible. It's recommended only by the CDC only when any other methods cannot be utilized. So you really have to keep a logbook and see how long they've been in there. Most items, in having to read the instructions for this, have to be submerged for at least 12 hours to achieve full level disinfection. So there has to be some type of monitoring system. And some offices I've seen will actually use two separate cold sterile solutions if they're using this. You don't really see it used too often at our university. Some offices may still be using this. The care of our sterile instrument is very important, as well as just as much as the processing. They must be stored with sealed wrappers. They cannot be punctured. They cannot be opened, that it would render them non-sterile. Yours will be in your lockers, in your assigned lockers. In most offices, they're going to be stored unopened in a clean, dry cabinet or a drawer. Re-sterilization may not be required for several months or even up to a year, depending the environment, as long as they're in a dry environment. Plastic or nylon wrap may be sterile even longer. And again, it just depends in the area where it's stored, how the shelf life is. All stored packages are usually dated and rotated and handled very carefully to prevent tearing. This is just a little reminder. You use our proper PPE and safety glasses, and especially with our cold and flu season that we're seeing right now. Chemical disinfectants are very important, and I want you to remember much of what we're talking about in this slide. We have a surface, immersion, or hand antimicrobial agents. The surface disinfectants are what we're going to use to clean all of our surfaces when you first get into the clinic. We use a cavi wipe that you see down here on the lower right. I think your textbook uses the spray wipe spray, which is this is another high-level disinfectant. We use a wipe, dispose of the wipe, and then we get another wipe when we're cleaning our surface disinfectant surfaces when you first get into the clinic. Again, we have a high-level disinfectant, and that's going to kill all spores, viruses, and fungi on our surfaces. We have an intermediate level disinfectant that inactivates, but it does not kill spores. And then we have a low-level disinfectant that is going to kill our vegetative bacteria, but it's not sporicidal, it's not effective against TB or some of our non-lipid viruses such as hepatitis B and HIV. Some of the considerations when we're looking at using our cavi wipe or any of these high-level disinfectants, when you're using them, they can be irritating to the skin, so you always want to wear a pair of gloves while you're using our wipe. When you come into the clinic and you're cleaning contact surfaces, your textbook mentions a spray wipe spray method. We want you to use a wipe, and that's going to wipe your chairs, wipe your surfaces, dispose of the wipe, and then get another wipe. So we're kind of use a wipe, dispose, wipe. When we're using, we always want to use an EPA registered hospital grade disinfectant that has tuberculocidal activity that also is effective against hepatitis B and HIV. And these are some of the properties just to take a review over with an ideal disinfectant. We want it to be a very broad spectrum, just so we were mentioning effective against the different microorganisms. Want it to be fast acting, odorless, not affecting by physical factors, especially that's where our wipes come into play. We used to use the spray wipe spray method, but a lot of times because of the aerosols in the air, people were having some problems, especially people with asthma, or they develop breathing difficulties. It must be economical, non-toxic. It must have a residual effect on the treated surfaces to kill the bacteria, and easy to use, and also surface compatibility, that it's not going to damage the items, whether it's going to damage our chairs or damage the countertop surfaces. It does have to have that surface compatibility. Next is our barriers and surface covers, and barriers are going to be used like handles on the light covers. We have a barrier over our tray unit. We may have a paper barrier on a tape on the rolling tray. We wrap our pens. The benefits with a barrier eliminates that contact time required by our disinfectant. It's chemical free and it's pretty efficient and safe. Just takes a little bit of time. We have to identify our areas. We always look around what we're going to need. We want to apply all of those barriers prior to our patient being seated, and we also want to make sure that they're secure. We don't want them falling off right in the middle of our procedure, and we have to touch a surface and then contaminate it. And then afterwards, you're always going to be wearing your PPE, which would be your utility gloves, those heavy-duty utility gloves. You're going to remove that carefully. Then you're going to clean and disinfect the surface, discard the barriers and the wipes appropriately. Then you're going to remove your contaminated PPE. Then, after you've done that, you're going to use hand hygiene, clean your hands, and then you can apply your fresh barriers and surface covers. And the preparation of our treatment room, I know we've been talking about that. Then that main objective is that just control disease transmission. Our patients don't really know infection control procedures, and they ask you, what do you do to clean these areas in between how do you sterilize your instruments, what is done. So all of these aspects are very important because patients are very concerned about that. It's always recommended as a clinician to sit in the chair that your patient is sitting in from time to time and look around your treatment area, making sure how the ceiling lights look, how the baseboards look, how everything looks from a patient point of view. As we continue with preparation of our treatment room, again, we're going to clean and disinfect our environmental surfaces. We're going to use that dispose wipe when you first come in. When you come into the clinic, you're going to clean the areas. You will then take your gloves off, wash your hands really well. Then at this time you can go to the cabinet and get your barriers and all the items that you need. Anytime, and if we're going to use a suction, you want to cover the suction with suctions with a barrier, your air water syringes with a barrier, your tray with a barrier, your chair with a barrier, the light handle covers, all of those items take into consideration what you're going to be covering. I believe there's a video that you're going to view that you have available so you can see how to set up that cubicle as well. Our unit water lines, biofilm or bacteria builds up in these water lines. At the beginning of the day, we're always going to flush our water lines for two minutes with that air water syringe. Then in between patients, we'll do it 30 seconds before and 30 seconds after each use throughout the day. And then at the end of our patient care, whether you see a patient in the morning or when you're seeing patients during the day, we always are going to flush our suction lines, those evacuation lines, especially those low-level suctions or the high vacuum suction. And then we're also going to flush that at the end of the day as well to prevent bacterial accumulation. This is an image of one of our recent graduates that is ready to see a patient. She has all her protective gear on, all her PPE, and then you can see the barrier on this chair. Here's one of our spray disinfectants. We have the coverage on the unit behind her. We have a barrier on the chair. There is her patient napkin ready to go. You can't see this very well down here, but there's also barriers on these controls on the sides of the chair. And although this is not one of the units in our dental clinic, kind of as a front view, kind of shows, okay, here's light handle covers with this area. There's a barrier cover here. Here's the suctions that are covered. The x-ray tube head is covered also, and that's in our x-ray area. You will always see those covered as well. Those are any type of touch and contact surfaces that we have. In patient preparation, we want to always use a pre-procedural rinse. The pre-procedural rinse does help prevent oral bacteria in the patient's mouth during our dental procedures. And also if we have to produce any aerosols, it also reduces the bacterial aerosols in the air. So toothbrushing is also another effective way to reduce the bacteria in the oral cavity prior to any dental treatment. Pre-procedural rinse can be an antiseptic rinse, such as Listerine or chlorhexidine. Usually we're going to hand this to the patient, just a small amount, about a tablespoon or two, and have them rinse for about 30 seconds. Then they can expectorate it into the cup. Sometimes with the use of a topical anesthetic, we always want to use that, and that when we're doing injections, and that reduces the bacteria as that needle is going into the tissue prior to an injection. So just a quick overview of the procedures as we're going to be going into clinic, and you'll see each other as peer patients, or when you begin to see patients. We're always going to look at the patient factors, and with that we want to look at their med history. We're going to have them do a pre-procedural rinse. We're going to give our patient their protective eyewear always. We're going to have our clinic protection before clinic preparation or our treatment area. We're going to flush our lines at the beginning of the day. We're going to disinfect our surfaces, and then we're going to apply our barriers. Always remembering for our dental team, wearing your PPE. What is the system for cleaning, disinfection, and sterilization of your instruments? And then our treatment factors. Always implementing standard precautions. And with our standard precautions, we're going to always treat every patient as if they are potentially infectious. And then post-treatment, we're going to use our puncture-resistant purple utility gloves for cleaning our treatment area and preparing the instruments for sterilization. Would like to mention, I know we had mentioned to get the small plastic shoebox. In the DH clinic, you're always going to transport your instruments in this shoebox and carry them to the instrument cart with your purple utility gloves. The disposal of waste, we always follow the OSHA regulations for disposal and also for labeling. The guidelines for disposal of waste in our clinic and in most offices, gloves, masks, the patient drapes, barriers, and other disposables are placed into the waste receptacle when you're done with patient care. Any sharps that are used are placed in sharps containers. This is a sharps container, and you'll see those in various areas throughout the clinic, in the dental hygiene clinic or in other clinics, or even on rotations. Or if you've worked in a dental office or been in a dental office, you may have noticed these. Here is the plastic shoebox, and we're actually going to put a biohazard label on those for when we're transporting those to the instrument cart for sterilization. And then some of the other recommendations. One of the recommendations that was made, cleaning the face in exposed areas. Most of the time we're going to have our mask on, we're going to have our eyewear on if you decide that you want to wear a head covering. But any exposed areas, you can wash your face. I've known clinicians that just prefer not to wear makeup, and they'll wash their face at the end of the day. Do not ever eating into our clinic. There is no smoking. We are a smoke-free campus, and most offices are, but there are patients that ask if they can vape, and that's a no as well. In the reception area, there should always be some hand sanitizer available. If you work in an office that has a toy area, there should be toys that should be able to be sanitized and cleaned easily. And then sterilization monitoring. There should always be records when we talked about the spores or how your autoclave was checked, all kinds of records that need to be, and those records should be accessible. And then there should be an office policy manual for emergency procedures as well that addresses your standard precautions for your office. And I'd like to discuss the occupational post-exposure management. Even though we're always as careful as we possibly can be, accidents can happen. So it has to be a significant exposure, and that has to be a percutaneous exposure with a stick with a contaminated sharp with blood, saliva, or other bodily fluids. And this accidental exposure could be a needle stick, it could be a laceration with a sharp instrument, it could be paramucosal if there was some blood splashed in the eye or in other mucosa. The post-procedure follow-up at UTHSC, the protocol is in the clinic manual, but we do notify our academic affairs, and they come and take a patient report from you and as well as the patient. There is always follow-up testing for the patient and for you, and then it's also any type of counseling that might be needed as well. And as we're going into the clinic for you to see each other as peer patients soon, and you'll be seeing patients in the next semester in our clinical areas. There is no eating, no applying cosmetics, again, no smoking, and again, that we still have some patients that ask if they can vape. We don't really see people that are smoking. We are a smoke-free campus, but some people will ask if they can vape in our clinic areas. Contaminated instruments are always processed in a separate area, so that's where your box comes into play. Our cassettes are used for transporting our instruments, and they also provide protection. Most offices should have an office policy manual. When you are first hired, they should always let you know where that is. As with UTHSC, we have our clinic manual. I know there's a clinic manual quiz, and you should be very familiar with your clinic manual by the time we get into clinic. And we're always going to have documentation. We have not started with documentation yet within the clinic, but everything is documented, and that is any type of irregularities related to our protections, special needs for the patients, unexpected treatment needs that may have happened for the patient that we need to have a referral. Are there any medical alerts? And even document for the patient with infection control concerns. And that's why it's so important that you're able to address this with your patient. Just some aspects that you can review with your patients, explaining to them why we use standard precautions, why we take a medical history, knowing how we use our sterilization, what our methods are, how we have different types of bacteria, how their biofilm control helps to keep that bacteria down. They'll ask a lot of times why we're using that pre-procedural rinse, and then also for thorough rinsing of the mouth. How long do we do it? Why do we do it a certain amount of time? Or have patients do a pre-procedural brushing as well. So this is just kind of a funny, just to remind you that infection control is kind of a big deal, and we want you to always follow the recommended guidelines and protocols for protection for both you, your patient, and as well as your families.